Welcome to part 4 of the MedFlight ultrasound curriculum. This talk was originally supposed to be a two-part talk encompassing all of thoracic ultrasound, including the lungs and the heart. However, because this is a pretty broad topic, there's a lot going on in these two fields, and so we split this up into two talks. The first talk that we're going to do today is going to be about lung ultrasound, and the second one, part 5, will be about the heart. If you can, I really urge you to take a break between these two so that everything is presented in digestible pieces. Today, we're going to focus on two questions pertaining to the lungs. Number 1, is there a pneumothorax and do the patient need decompression? And number 2, are the lungs excessively dense as they would be in ARDS or pulmonary edema, and would fluid hurt these patients? We'll start by talking about some background concepts, then the scanning technique itself, and then some pearls and pitfalls of this particular scan to prevent you from falling flat on your face. Let's start with the background. Lung ultrasound is different from exams looking at free fluid we discussed last time. When you do a FAST looking for free fluid, you'll see the organs bouncing off sound in a very predictable manner, making them look a lot like those organs do in real life. So a kidney kind of looks like a kidney. With lung ultrasound though, sound bounces in an air-filled bellows. This produces a ton of artifacts that we'll talk about because sound doesn't move predictably in air the way it does in fluid. Interpretation of lung ultrasound relies on analyzing and understanding these lung artifacts. So when you first put the probe on the patient's chest, here's what you'll see. On either side, there are dense shadowing ribs, seen here, with a pleural line running just below the ribs, which represents both the visceral and parietal pleural layers rubbing against each other. Normally, when the visceral and parietal pleura are touching in a normally inflated lung, you'll see a shimmering movement of the pleural line as the two layers slide by each other during the respiratory cycle. On the other hand, if a lung has collapsed due to a pneumothorax, like you see in the animation here, the two layers aren't touching anymore because there's air in between, and you'll no longer see that sliding movement. The second basic concept to understand is that air will rise to the top. This is a big reason why trauma supine x-rays are often useless. Here's an example of a relatively normal appearing chest x-ray, and here's the CT scan on that same patient. Time and time again, we've found that the sensitivity of these chest x-rays is quite lousy, somewhere around 40%. By contrast, lung sliding on ultrasound has a sensitivity of 79% for ruling out pneumothorax. Let's synthesize these two basic concepts into a formalized scanning technique. There's a significant debate about which probe to use. Recall that high-frequency linear probes have very good resolution at superficial depths, and as a result, many folks prefer to use this probe for pneumothorax detection. Nevertheless, a number of groups, including in the pre-hospital world, have found that curvilinear and phased array probes have adequate performance. We'll start by showing the images obtained with the linear probe and then discuss how this can also be achieved with our MedFlight phased array. First, use the concept that air rises and position the probe on the highest point on the patient's chest with the indicator pointed towards the head. Visualizing lung sliding in this region virtually rules out pneumothorax, and then you can move on. Since many of our patients have significant soft tissue, you should also slide the probe up and down a rib space to make sure you're not missing a small pneumothorax in the anterior chest. Occasionally, especially in the beginning, you may be unsure if you're seeing sliding or not. If that's the case, you can use something called M, or motion mode. This will allow you to track movement of just one minuscule plane over time, in this case, right over that yellow line. In normal lungs, seen here, you see that below the sliding pleura, there's movement, and that movement creates a heterogeneous grainy appearance. This pattern is often called the sands on the beach pattern, with the pleural lining being where the waves meet the beach. On the other hand, in a pneumothorax, what you'll see is a kind of linear appearance below the pleural line. This is often called a barcode sign because it's the same above and below that pleural line. Here's what the two patterns look like side by side. On the left is the normal lung and on the right is the pneumothorax. If you forget which one is which, remember, sand on the beach, time to relax, barcode sign, time to pay up because your patient might have a pneumothorax. Why do I say might? It turns out that there's a lot of reasons that a patient might have absent lung sliding or a barcode sign other than a pneumothorax. These mostly have to do with other causes for decreased air movement, including things like COPD or asthma, obstructive lung disease, mainstem endotracheal intubation, and apnea. But of course, you probably shouldn't be using ultrasound to detect apnea. How can you differentiate between these other causes of diminished air movement and a true pneumo? Once again, remember that the pneumothorax will rise. This means that there will often be a point where the pleura once again reattaches, and you can easily find this point by sliding the probe posteriorly on the patient's chest to get to the more dependent portions of the chest wall. When you do this in a patient with a pneumothorax, you'll find that lung point, which will show an area of sliding dependently next to the area of no sliding. This is highly specific for a pneumothorax. Some reports have even claimed 100% specificity in the right patient population, but we'll talk in a little bit about some pitfalls to assuming that's the case. First, let's summarize the scanning technique. Start with the highest place in the chest, slide up and down to find a spot with a pneumothorax, and when you find it, slide down until you see a lung point. Sounds pretty easy, right? So what are these pearls and pitfalls that can trip you up? The first one to be aware of is subcutaneous emphysema, which often accompanies a significant traumatic pneumothorax and can make ultrasound very difficult. Here's an example. What you're seeing here is something that looks like the pleural line, outlined in blue. But notice at the end of the clip that this lies above the rib. This is actually subcutaneous air mimicking a pleural line and is called an E-line. This is one reason it's so important to start with the sagittal orientation in order to make sure that the rib is in your field of view and what you think is pleura actually lies below the ribs in the appropriate space. Unfortunately, this will make ultrasound completely useless. Though the good news is that if this person is unstable, they will very often need a chest tube since they are very likely to have a pneumothorax and you can detect subcutaneous emphysema clinically. Next is something called a lung pulse. This is where the pleura moves at the same rate as the patient's heart rate rather than the respiratory rate. It's more often seen on the left side because that's where the heart is, and in abnormally inflated lungs. Fortunately, the reason this occurs is that the heart's pulsations are transmitted through the lungs to the visceral and then the parietal pleura. This means that the two layers of pleura are touching, and this also will rule out a pneumothorax. Now, the biggest pitfalls have to do with this assertion that the lung point is 100% specific for pneumothorax. While this is true in studies looking at the appropriate clinical context, there are a number of things that can throw you off. The first is that the lungs can also be adjacent to other non-sliding organs, such as the heart or the diaphragm. And if you aren't cognizant of where your probe is positioned anatomically, you may be fooled by this interface. So pay attention to where your probe is physically. You should also realize that if the pneumo causes complete circumferential separation of the pleural lining, you won't see a lung point. The silver lining here is that those patients usually have those more classic findings of tension pneumothorax, like mediastinal or airway shift and jugular venous distension, making it much easier to justify empiric decompression. Finally, there are other lung features which can cause focal absence of lung sliding, such as Bleb's adhesion and pleurodesis. How do you get around these? First, make sure that the lung point makes sense and that the lung point is actually dependent. Posterior Blebs might look like a lung point, but it will look backwards. The sliding will be more anterior, and the dependent portion will be where the air is. Now, what about more pesky anterior Blebs? If you're less worried about the spine, you can certainly sit the patient upright to see if the pneumo and consequently the lung point will move to a more antidependent region, which a stuck-on Bleb or pleurodesis adhesion will not. However, there are also some lung artifacts that you need to know about which can also tell you if the pleura are touching, and more importantly, can tell you if the lung parenchyma is too dense with fluid and inflammation, which suggests that you can harm your patient by giving too much fluid too fast. The first artifact you'll often see produces horizontal lines called A-lines. This is essentially a reverberation artifact. In this case, the sound will bounce off of a reflective pleural line and then hit the chest wall, where it will get reflected back to the pleural line and become trapped in this vicious reverberation cycle, going back and forth within that chest wall space, occasionally making it back to the transducer at regular time intervals. These time intervals are interpreted by the machine as depth, and you will see these regularly spaced A-lines. This can be seen in normal and dry lungs, but even more common in hyperinflated lungs of patients with COPD or vented patients getting a lot of autopeep. This artifact, unfortunately, arises only from the parietal pleura, and so tells you nothing about whether the two layers are touching, so it can be seen in pneumothorax as well. Here's a good example showing A lines persisting at the lung point on both sides of the lung point. So on the left is the lung point here, and on the right is an area of no sliding. Now, as the lungs get a bit more dense, they will often produce little vertical reverberation artifacts in the area of density called Z lines. These areas of density are typically normal structures like interlobular septa, and so these vertical comet tails only go to a few centimeters in depth. These are normal, and because they are visualizing lung parenchyma, necessarily mean that the pleura are touching and will also exclude a pneumothorax. Here's that earlier view I showed you with those little comet tails going down just a couple of centimeters and kind of disappearing pretty quickly. The last artifact to talk about are B lines. B lines represent confluent areas of density and look like long comet tails that go all the way down to the bottom of the screen, even at higher depths. Typically, you need to be at least 13 to 15 centimeters deep to make sure that B lines are going all the way down and aren't just long Z lines. These findings are found in very dense lungs, such as those seen in patients with pulmonary edema, ARDS, or focal infiltrates like pneumonia. These lines also originate from the visceral pleura and exclude a pneumothorax. Remember, when you see B lines, be very careful about volume resuscitation of these patients. These patients are typically volume overloaded with a very tenuous respiratory physiology, and you need to be very careful about overloading them with more volume. They don't, however, have a pneumothorax, so please don't decompress these patients. Let's summarize this portion. A lines can be present in pneumothorax or no pneumothorax, so they don't tell you anything about the presence of a pneumothorax. However, B and Z lines will both rule out a pneumothorax, and B lines will typically represent very dense and volume tenuous patients. Once again, summarizing the scanning technique, start at the anterior chest, go up and down to find an area of no lung sliding, and if you see this, go down in order to find a lung point. Remember that pneumothorax should really be suspected in patients with no lung sliding, with a lung point, and make sure that that lung point obeys gravity. Pneumothorax is ruled out if there is lung sliding, if there is a lung pulse, or if there are any of those visceral pleural artifacts like B or Z lines. So far, I've been showing you these beautiful pictures with the linear probe, but what will they look like with the phased array probe? Most of the time, you will be able to see sliding reasonably well just by putting the probe in the same location. Note that the gain here is quite low to make sure that you aren't overexposing the pleural line and can actually visualize that sliding. So the first key with the phased array probe is to minimize your gain. Now, if you're still unsure, the next thing to try is to decrease the depth so that you're focusing in on the pleural line rather than wasting all that deep underexposed space. So here's that same patient focused in a little bit more with lower depth. So that's step 2. Minimize the depth so that you're focusing in on the pleural line. Now, occasionally, especially in very thin patients, the probe will have a hard time focusing on that very superficial pleural line. Now recall that we have been doing most of our exams in the fast setting when you first turn on the machine. However, you can go to the upper left-hand corner menu and select the lung exam. The lung exam will allow for better visualization of the pleural line, and so that's the next adjustment. Turn on the lung settings. Now notice here that occasionally the lung sliding will stop and then it'll come back. What's going on with that? Here's another example. Sometimes it looks like they're sliding and sometimes it looks completely still. What this is the patient taking a breath in and out. So remember to ask your patient to breathe when you're looking for air movement, because if they're not breathing, there's no air movement. If they're vented, look while you're giving them a breath. Finally, our machines do allow for M mode, and you can always fall back on this to really confirm that there is or isn't pleural sliding. So to recap how we're going to do this with our phased array probe, minimize your gain and your depth, use the lung setting, remember to ask the patient to breathe, and when in doubt, go back to M mode. For the time being, we'll continue using only the phased array probe. If this isn't working out for us though, we'll definitely readdress and consider getting a separate linear probe. So keep your feedback coming. Here's a few resources for you to review.